Good afternoon, everyone. I see folks are still kind of trickling in and getting connected to audio, but I have 1 o'clock Eastern, so I want to kick off our call today. And again, welcome you all back to another week of Superior Health COVID-19 Nursing Home Leadership Roundtable. I'm sure by now you know sort of our core team. My name is Kelsey Ostergren, and I'm joined by Jerry Hineker and Kim Healt, who are program co-leads for this work. In addition to Kim, we also have Tony Kettner, who will be taking a few minutes at the end of the call to discuss real-time medical solutions. And then our very own Kim, who will be talking about flu vaccines for healthcare personnel. As always, just want to open an invitation to all of you to engage in this session in whatever capacity feels comfortable for you, whether that's via chat, which I know we've had really great engagement in chat over the last few weeks, or if you're comfortable unmuting your phone lines and sharing verbally as well. If there are other questions that you have, even if it's unrelated to our topic for today, please ask those as well. This really is your time to get feedback from your peers as well as from the team at Superior Health. And I know we always have quite a team here and can answer any questions that you might have or potentially slate it for a topic in a future week. So we do have slides available for today. Just to note, there will be 2 separate slide decks. So Kim has a deck and Tony has a deck. I see Jerry put the links in chat, so just make sure you click on both links because again, there are 2 separate decks that we'll be talking through today. As always, we will share a link at the end of the session to the event evaluation form and would appreciate any feedback that you can provide us, as well as suggestions for future topics. We look through these every single week to try to pick out if there are anything that you guys have sort of escalated and want us to talk about, because this really is your time. So we want to make sure we're meeting your needs. If there are things that are pebbles in your shoes or things that are keeping you up at night, please let us know, and we're happy to incorporate a future topic on that during one of these sessions. So with that, welcome, and Kim, the floor is yours.
Excellent. Well, thanks, Kelsey, and hello, everyone. Nice to see the same faces again. Maybe a couple new ones is always excellent. Today, we're talking about the SNF QRP measure that came out earlier this fall, the influenza vaccination for healthcare personnel. Our objectives today, we're going to do a very brief overview of the influenza virus and the importance of vaccination. Then we're going to review the HCP Influenza Fiscal Year 2023 SNF Quality Reporting Program Rule Requirements. Then we're going to talk a little bit about COVID-19 vaccination data. And then, like Kelsey said, we'll turn the floor over to Tony for a brief explanation on real-time solutions. So influenza or flu is a contagious respiratory illness caused by the influenza virus, and it affects the nose, throat, and lungs. Common flu symptoms are fever, cough, sore throat, runny nose, body aches, headaches, fatigue. Sounds a little bit like COVID, doesn't it? Anyways, each year, the flu causes outbreaks in our long-term care facilities, and the impact can be devastating, especially for the older population, ages 65 and older, which of course we know compromises the majority of our long-term care facilities. They account for the majority of flu-related deaths and hospitalizations in the US each year. And vaccination is one of the most important strategies to decrease flu and COVID morbidity and mortality rates. Now, the CDC Morbidity and Mortality October 21-22 report, that's on this picture here, surveyed an internet panel of over 3,600 healthcare personnel. And out of those 3,600, 4 in 5 had received the flu vaccine last season, and 2 in 3 of them received a COVID booster after getting the primary COVID vaccine series. I think those are pretty darn good rates. Now, ACIP, that's the Advisory Committee on Immunization Practices, recommends that healthcare personnel receive an annual influenza vaccination and COVID vaccines to remain up to date. ACIP also recommends requiring healthcare personnel to receive flu and COVID boosters. So every flu season, the CDC conducts an opt-in internet panel survey and to provide estimates of influenza coverage among healthcare personnel. So this line graph represents the 2010-11 to the 2018-19 flu season, and then the percentage of vaccinated healthcare personnel in the various healthcare settings. So if you look at the first dotted line, that represents your hospital settings. The second solid blue line is all healthcare facilities, followed by ambulatory care physician offices. The next line is other clinical settings. Those are dental offices, pharmacy, labs, those types of settings. And then at the bottom of the graph, the lowest rates are among healthcare personnel in our long-term care settings. So your nursing homes, SNFs, home health agencies, assisted livings, those types of settings. And that red circle, that is, again, that's the point of the 2018-19 season for the long-term care settings, and that is at 68%. Again, 2018-19, I do happen, though, to have the last two seasons. So the 2021-22 and the 2021 season. Unfortunately, I wish I could say these rates have gone up, but last season was 66.4%, and the season before was at 66%. So also from that same 18-19 survey is data on a requirement of influenza vaccination for your staff in healthcare settings. Now, the highest rates of vaccination are in settings that require it as a condition of employment. So you'll see that the healthcare workplace requirement for the 18-19 year was at 98%. Last year's, I don't have it on a slide, but was at 97%. Only 30% of long-term care settings require vaccination, and that was in the 18-19 season. Last season, the rate had gone down. It's between 23 and 24% require influenza vaccination. Now, settings where vaccination is not mandated, it's not promoted, offered on site, I guess it just isn't even talked about, has the lowest vaccination rates at 42%, and that still holds about the same rate for last season also. So besides the requirement to report influenza for your healthcare personnel, there are benefits for measuring your coverage, your influenza coverage. Collecting and monitoring your data allows you to recognize vaccination trends and may help in identifying unvaccinated staff. Now, the healthcare safety component in NHSN, it's designed to ensure that your HCP influenza vaccination coverage is consistent over time within the long-term care facility and then comparable across facilities. So many of the same interventions and strategies we use to improve COVID vaccination rates, they probably hold true for influenza. What we do know is that vaccination is highest when it's a requirement for employment. Several studies had demonstrated that healthcare personnel influenza vaccination, it reduces patient mortality. Those healthcare facilities that have implemented a requirement for employment have reduced employee absenteeism and healthcare associated influenza. So thereby, of course, improving patient safety and reducing healthcare costs. Now, the influenza and pneumococcal immunization toolkit that's created by Superior Health And the CDC's long-term care influenza kit for providers houses various resources on campaigning, education, motivational interviewing, billing, and all sorts of other things. I encourage you to click on those links and use those resources. So the SNF QRP measure number 12, influenza vaccination coverage for healthcare personnel. This was finalized in the fiscal year 2023 SNF PPS final rule. There's 16 SNF QRP measures, and these requirements are mandated by the Impact Act of 2014, if you've heard of that before. Every year by October 1st, CMS publishes the QMs SNFs must report on. The purpose of this program is to improve Medicare beneficiary outcomes through accountability and public disclosure. Now, data collection for the SNF QRPs, they're submitted through three methods. You have your MDS submission, your Medicare fee-for-service claims, and in this case, NHSN, the National Healthcare Safety Network. There are now two measures in NHSN. You have the first measure, that was number 11, COVID vaccination coverage among healthcare personnel, and now the influenza vaccination for healthcare personnel. Now, SNFs must submit 100% of the information required for this influenza vaccination. Actually, it's 100% for COVID too. And to calculate the measure, and failure to submit can result in a 2%, actually I shouldn't say can, I believe it will result in a 2% reduction in the SNF's annual payment update rate. Reporting requirement details. So the data can start being collected as of October 1st of 2022, and it goes through March 31st of 2023. Once this collection of data has been obtained, the measure begins fiscal year of 2024. Now, one submitted report is required for the influenza season, and the reporting deadline is May 15 of 2023. Data for the influenza vaccination summary is submitted through the NHSN Healthcare Safety Component in NHSN. So this screen shows the view for the annual influenza vaccination reporting. This is the HPS component, and it's the NHSN facility administrator. So that person that enrolled the facility into NHS is the only person who can activate additional components for the facility. This is that same person that could add, delete rights in a facility, add users, so on and so forth. And this is the only person who can reassign the role of an NHSN facility administrator. Now, each facility, I highly recommend, should have at least 2 NHSN users, one of them being the NHSN facility administrator. I'm going to go off tangent a little bit here, just because I want to talk about a change in NHSN administrator. To be proactive, and you know that your NHSN administrator is leaving, is going elsewhere, what have you, the proactive thing would do is, prior to them leaving the facility, to have them change the facility administrator rights to someone else. But we don't always get a chance to be proactive. So if you need to be reactive, don't worry. You can use this change in NHSN facility administration, and oh my gosh, administrator form, and submit that to have the administrator's name changed. Whatever you do though, please do not re-enroll the facility into NHSN. Okay, going back to that HPS component, what you want to do as the facility administrator is, of course, log into SAMS, click on NHSN reporting. From that home page, click on Add Edit Component, check the box for the healthcare personal safety component, and then add your contact information. Now, it doesn't have to be you as the NHSN facility administrator. If you want someone else to be responsible for this component, you can add their contact information, and then they will receive updates in this area, or if there's questions about the HPS component, they'll reach out to this person. Okay, now there could be some confusion about where to report the data. Reporting weekly influenza vaccination data through the NHSN long-term care facility component, it does not. This is the big warning X. No, do not do this at all, because this does not fulfill this reporting requirement. And where it's going to be confusing is this is a change from previous information that stated more frequent reporting could also meet this requirement, but it does not. The key points document, and I'm going to have my team put this link into chat for you. It's a real nice one-pager. Talks about the new update and about how the requirement is that a single summary report covering the entire reporting period for the season is required. Okay, so just so we're on the same page, we have 2 NHSN components that you're submitting data into for the 2 SNF QRP measures. You have the annual HCP influenza vaccination summary that is going to be reported in the healthcare personnel safety component. And then you have your COVID vaccination summary that you've already been doing, and that is being submitted weekly into the long-term care facility component, 2 components. The influenza summary, it consists of, that you're going to be reporting on, consists of 6 questions about facility and non-facility employees. And the columns or the denominator, those are the employees, and then the the columns or the denominator are they're the employees, and then the rows or the numerator consists of the questions, the 6 questions. Under the denominator categories, there are required and optional sections of the summary. Denominators can be calculated separately for the 3 required categories, but they can also be calculated for a 4th optional category. So staff on payroll, required. That includes all your healthcare personnel who have worked at the facility for at least 1 working day during the reporting period, October 1st through March 31st, regardless of clinical responsibility or patient contact. Working for any number of hours a day counts as 1 working day. Also required, non-employee required people, the first category would be licensed independent practitioners. These are your MDs, DOs, NPs, PAs, post-residency fellows, anyone that's affiliated with the facility but does not receive a paycheck. The other required non-employee positions are health students, trainees, and volunteers. This is defined as medical, nursing, or other health professional students, interns, medical residents, volunteers, 18 or older, that again are affiliated with the healthcare facility, but not getting a paycheck. So here we go to this other contracted personnel. This is optional at this time. I wonder if that'll be changed, but right now it is definitely optional. And this is defined as a person that's providing care, treatment, or services at the facility through a contract. And there's several types of contracted people. These could include your therapist in your therapy department, your pharmacist, travel nurses, agency staff. There is a huge list, and that's on this link here so that you can refer to the people that fall under this contracted category. So your numerator categories. The numerator includes your healthcare personnel who received an influenza vaccination during the time from when the vaccine became available through March 31st of the following year. So if I get my vaccine on September 1st and I work in my facility on October 1st, I am now counted as a person, a healthcare personnel that did receive my influenza for the reporting period. So if your employee, though, does receive an influenza vaccine elsewhere, you do have to have documentation of that for it to be counted. So a signed statement or form, vaccination card, something valid, and there is links in the resources so that you can get a better understanding of what is allowed. So no verbal statements are accepted for influenza vaccinations received elsewhere. The other category you'll be filling out is medical contraindications, and there's also a list of those too, and that's found in the resource section for you to review. What is interesting here, though, for the medical contraindications, though, is that documentation is not required for this. Verbal statements are acceptable. And then you'll also be documenting declinations. Documentation is not required for reporting. Verbal statements are also acceptable. Under unknown status, I guess pretty much self-explanatory, or criteria not met for above mentioned categories. So that concludes like this key points, like high overview to understanding the SNF QRP influenza vaccination coverage measure for healthcare personnel, but also recently updated is Care Compare and the provider data catalog with the October 2022 release of the SNF QRP data. So you can use the provided link here to view your quarterly submission dates used for this release. But I wanted to point out that the COVID vaccination coverage among healthcare personnel was released this month. So the measure will display vaccination data submitted October 1st through December 31st of 2021. And just a high overview of where you'll find that new measure is in Care Compare. Just click on quality measures, short stay, and you will find the new measure with the rate from that reporting period in that section. So Care Compare, though, also, they really like putting the COVID data out there because they have it in two places. In the one I just talked about under the short-term quality measures, but it's also on the landing page of Care Compare. And the COVID-19 data comes from, the data on this page comes from data.cms.gov, the COVID-19 nursing home data. The metrics are 2 weeks behind from the data that you report into NHSN. Now, your facilities are in the public eye, so anyone can view your nursing home COVID vaccination rates on both of these sites. So it's pertinent to be presenting your nursing homes with accurate data. Since the last up-to-date COVID vaccination definition went into effect in September, don't be surprised if you see that your COVID vaccination rates that maybe were once in the 80, 90 percentiles have gone down to single-digit percentiles. That's because of the change with up to date. So let's review that. The CDC and NHSN COVID vaccination up-to-date definitions, they're the same. The CDC recommends that people ages 5 years and older receive one updated, meaning bivalent booster, if it has been at least 2 months since their last COVID-19 vaccine dose. And that's whether that was their final primary series or an original monovalent booster. People who have gotten more than one original, the monovalent booster, are also recommended to get an updated bivalent. Now that's a lot of words at one time. And what I really like here, though, is this decision tree. I find this really helpful. You can use it when determining up-to-date vaccination status. And for NHSN, use this up-to-date definition during the surveillance period. So when you're reporting between the quarter of September 26th of 2022 and December of 2022. Nope, December 31st. I think I missed. No, I am so sorry. You're going to make sure that you're reporting this way between September 26th of 2022 and December 25th of 2022. But looking at this really quick, yeah, look at this. This is so cut and dry. Have you received an updated bivalent booster? Yes, you're up to date. No, did they receive their last booster dose less than 2 months ago? Yes, they're up to date. No. Did they complete their COVID-19 primary series less than 2 months ago? Yes, they're up to date. No. Use this maybe for your staff, maybe for the family, your residents type of thing, because at least this is an easy way to identify the needs of what up to date is. And of course, always my resource page, and we'll do some questions later on. But right now, I definitely want to get Tony on board. And so give me just a minute here.
Thanks, Kim. While we're waiting, that was an excellent presentation. So thank you for all that really valuable information.
All right. Thank you very much. It's coming. It's coming right here. Okay, and I'll start sharing. Let me get it up. Sorry, Tony.
No worries.
Okay.
When you're under pressure, it's can be stressful.
Okay, it's loading. And let me share my screen. All right, I think we may be in business.
Okay, awesome. Thank you.
So
we have, I was asked today just to come and give this brief presentation about this really great opportunity and partnership that Superior Health has with Real-Time Medical Solutions. Next slide.
Why won't it advance? And there it is.
Awesome. Okay. So Real-Time Medical Solutions and Superior Health Quality Alliance entered this partnership, which goes through October of 2024. And I think one of the key highlights to remember is if a nursing home or a single entity or a corporation wishes to participate in this program, there's absolutely no cost to you to join the initiative. And I think that's huge. We don't get many things for free now and get to try something for 2 years. So really an awesome opportunity. So a little bit about Real-Time. It's a post-acute analytics software application that actually sits on top of your electronic health record. So very different, those of you who've had the occasion maybe in your facilities to integrate a new EHR system. This is something that just sits on top of that. So one of the key points is that you are not having to document anything other than what you're already documenting through your current practices in the facility for documentation. So I'll talk about that a little bit more in a bit here, but it does integrate with your nursing home's electronic health record. And so it's very compatible with Matrix, Point Click Care. There's a couple others that I wasn't real familiar with, but you have to remember that real time is nationwide. So some of these are probably applicable in other states. Some of the other ones are Optimus, EHR, Sigma Care, and American Health Tech. For those in Wisconsin who may use American Data or electronic or EHS as we sometimes, or ECS as we sometimes refer to it, currently that's not supported for real time, but they are working on that for in the future. So what happens is this software application sits on top of your electronic health record, and through a series of algorithms that they have set up, and also through a series of some like keywords that they have built into the system, it's pulling real-time documentation from your electronic health record into this real-time medical solutions. So that, for example, when you get there in the morning to your facility, you can actually look on this really nice dashboard, and it stratifies patients according to their risk as high, medium, and low risk. So it has a lot of applications, I think, to help maybe improve efficiency in this day and age when we're all struggling with staffing. So for example, if I were the director of nursing or registered dietitian, it applies across the board to all the interdisciplinary care teams. I could go into the facility, I could look at these reports, and there are reports for a wide variety of quality measures: antibiotic stewardship, falls, infection prevention and control, medication safety, all kinds of different things. And I could look to see in that report which residents were triggering in that specific data. So for, let's say, for example, I got into the facility and I was looking at some of my infection prevention and control dashboards, and I could see that there were like 5 individuals that were triggering high risk for infection. So I can actually do a drill down and actually see what's going on and why they're triggering. And then it would be really easy to say to my licensed staff, wondering if we could go out and do kind of a more in-depth assessment of these 5 individuals today. It looks like maybe they've got some things that are pulling from their record that look like they there's an infection perhaps brewing, and we need to keep a closer eye on it. You could also go to your nursing assistants and say, hey, it looks like Tony might be having some issues, or again, there might be some kind of infection possibility going on. Can you monitor these things for me today? And we're going to do these following interventions. So lots of application in helping you be more efficient and to identify where there are issues that are occurring in your building. Next slide. So these are just some of the benefits, and I'll kind of let you read through those. Some of the other applications that are available is that it will help you. So you know how you get your quality measure, your data reports from MDS, and you have to do, you go into the MDS, the IKEY system, and you can pull down and look at resident specific data to see why an individual is triggering for a certain quality measure. This actually gives you the opportunity to do that before the MDS occurs. So again, it's a nice way to affect some interventions and to find out who, again, those folks are that are hitting in whatever quality measure it is that you're looking at. And again, be able to do some interventions in a more real-time and more proactive kind of situation. Let's see, also just some of the other things, there's applications for chronic disease prevention, management, and treatment. They have lots of reports in there. And again, they stratify residents in terms of whether or what their risk level is for readmission, again, which could be huge and has the potential, again, for you to be able to implement some interventions, reduce those hospitalizations, save costs, improve quality of care. Next slide. So I thought it would be helpful. These are two documents that if you're interested in knowing more about real time, there's a nice flyer that kind of gives an overview of the Superior Health Partnership with Real Time Medical Solutions. And we've had a couple of video demonstrations that we've done for folks. So this is one of them that we recorded. It's only 30 minutes, so it gives you a really good overview of some of the reporting capabilities, what the dashboard looks like. It just gives you a nice overview of the real-time medical solutions. So if you're interested in knowing more about it and it seems intriguing to you, you can look at those couple of resources, and then certainly you can feel free to reach out to me at any time. And if you want, I can get you connected to someone at Real Time, and they can give you some additional information. So I guess I'll just pause there, and I don't know if we want to, how we want to handle, if there are any questions about that.
Yeah, so Tony, thank you so much for giving this overview. I think this is a really great opportunity. And like you said, how many opportunities do we get to try something for free for 2 years and see if we like it? Yeah. With that, let's pause and see if there are any questions from folks on the line for Tony related to this real-time solutions that she discussed.
I know we do have a corporation in Wisconsin that's joined and is really looking forward to the opportunities for improvement and the possibilities. I think that again, it's just got huge opportunity for possibilities to really help streamline efficiencies in the nursing home setting. Let's see. So how will Superior Health be using the information? Okay, so yes, as part of the partnership, when a nursing home joins, we will have access to the nursing homes who participate. We'll have access to their aggregate data, so that we will be able to look high level at oh gosh, it looks like there's this many readmissions for this particular disease state or whatever the case might be. So thanks, Jill, for asking that question. So as part of that partnership, there is that data, that aggregate data sharing agreement.
And I think to that end too, and Tony, you're certainly the expert in this, so correct me if I'm wrong, but from the nursing home standpoint, this gives them the ability to spend their time much more wisely and doing some of those very targeted, focused deep dives on the residents who might need it. And then on the flip side, for us in Superior Health, it sort of gives us a sense of, okay, maybe diabetes management is something that in the whole, we see lots of nursing homes are struggling with. What can we do to support you as homes to help you or equip you with tools or skills to manage that better? Is that accurate, or is there anything you'd add?
No, that's very well stated. So it's got benefits for both, obviously, but in terms of our being able to be more supportive, it's really helpful when we have this data to know, well, what resources should we develop, or what might resources look like to help better support the nursing homes who are participating. And then, of course, when we think about it, that doesn't just apply to the nursing homes who are participating in real time. We can spread that more broadly to everyone who's participating as part of Superior Health.
Yeah, which I think is an important distinction too, that there will be widespread benefits regardless of, who participates. The other question I would have for you, Tony, is do we have any sort of target or deadline for when homes need to express interest and get up and running in the program?
Yeah, so good question, and thank you for that. So right now I'm working so we have kind of sort of waves of recruitment, if you will. So right now we're in the recruitment period. We're attempting to get 100 nursing homes to participate if we can by the end of this year, so December. We've got 71, so we are well on our way, and we have a couple of other corporations that we're working with that have expressed expressed interest. We do have the larger capacity to have 300 nursing homes participate. So there's lots of opportunity for people to join even after the first of the year. Obviously, the sooner you join, the more benefit that you get from it.
Wonderful. Are there any additional questions from folks about this platform?
Tony, also, would it be safe to say that like these could be, our participants could be from individual nursing homes, but as a corporation though, are you also looking at recruiting?
Yes, so right now we have a large corporation in Wisconsin that has agreed to sign on all of their nursing homes. But then we also have some just individual nursing homes that have expressed interest. So anyone is welcome to join, regardless of whether you're a large corporation, mid-size, small, or whether you're a standalone nursing facility.
Great, thank you.
Mm-hmm. Again, if there are any other questions, people can certainly feel free to reach out to me, and I can get those questions answered. And just wanted to say thank you for the opportunity to allow me to speak on this a bit today and just share this great, awesome opportunity.
Tony, I think a question came in.
Yes. Is there a more detailed? So I would think that that's a good question. I would think watching that 30-minute video recorded demo that we did would be a really good place to start.
And Tony, I'm also going to put your name and email address in the chat as well. I know it's in the slides, but Angie, for you to jot it down and others as well, as you're looking through these resources, reach out to Tony if you have any questions, and she'll connect. If she can't answer, she'll connect you to folks who can, but she's really leading the charge on our end related to this. So definitely take a look both at that YouTube recorded video that we've done to the demo of the site. I think that's a great opportunity to engage with other folks in your facility who might be using this, just to get a sense from them of, is this going to be a value add for their workflow and their processes, sort of talking through that with them before you sign on and agree. And, it's something that ultimately doesn't get used. So I do think it's important to have that discussion with folks in your facility, review the materials that Tony provided, and then certainly if there are additional questions, reach out to Tony or reach out to any of us and we'll connect you with Tony, and we'll make sure you get your questions answered.
And just one last thing too, it doesn't just apply to nursing. So just to keep that in mind, it can, for therapy, there are applications. For the registered dietitian, I think there are applications. So it's really kind of across the interdisciplinary team that this has capabilities to help support.
And I do see Elena, thanks for dropping the link in chat. So that's the link directly to that recorded presentation that Tony and I have been talking about. So take a look at that. And then to Tony's comment, if there are folks in your facility that this would be pertinent to, please pass it along to them, whether it's dietary or therapy or whoever else. It certainly isn't exclusive to this audience only. So again, as you're having these conversations and thinking about utility of a tool like this, just getting everybody's feedback and just making sure folks are on board before you move forward, I think will help once the tool does go live in your facility, that everybody knows what it is and how to use it, and you can sort of work through that process together.
Thank you.
All right, Tony, well, thank you so much. I don't see any other questions in chat at this point, so I'm going to kick it back to Kim's presentation and just open the floor if there are any comments related to anything Kim covered, NHSN related, vaccination related, either COVID or influenza, any questions about the wealth of information Kim shared with us.
Well, if anybody is thinking of a question, while they are thinking of a question, I was interested to know from the participants if any of you in your facilities, if you do require the influenza vaccination as a requirement for employment. And if so, how has that worked out for you? And, or maybe if you do, why, and if you haven't, would you think about that? Or is that something that you wouldn't even want to do right now? Go ahead and like put that in chat or whatever. I just want to give you a little background of where I used to work. Now, this was prior to COVID. And I remember when our CEO indicated that we were going to require influenza in the nursing home for all of our employees. And we thought that everyone was going to quit. Not, I mean, not everyone, but right, you know, a lot of the same thing about, you know, mandating the COVID vaccine, the same feelings of the influenza vaccine. Been doing it. That happened like about 10 years ago. And I don't think we lost any employees. And if we did, maybe one, I don't even remember anymore, but it's still a requirement there. In fact, because I just talked to the IP and said how that was going. And she said, yep. She says it's still a requirement. Just like always, we have those that jump on board right away, and then I will be hounding them some to the last minute to get their vaccine. You know, almost like running down the hall with the shot, saying, "Come on, you got to get this." You know, which yes, held true about every year that I can remember. But I found it interesting, though, that it is still mandated and it is still a practice that's not causing any issues. And I thought maybe it would, right? Because of COVID and the mandate of that vaccine. So maybe it was a good thing we did that early before COVID and not after.
So Kim, I'm seeing a couple chats here. Vicki said, we do not require the vaccine and administration is very opposed to doing so. Angie also said they do not require, they don't require the vaccine, but they do require signing a declination form. And so she went on to say they've achieved 80 to 90% every year without the requirement, but it's getting increasingly difficult year over year, and anticipate this year yet again will be a challenge too. Another comment here from Christine, they also do not require vaccinations, but are offering them. 98% of elders have received flu and 80% of staff. So really good uptake in vaccinations, yes, regardless of the fact that these facilities are not mandating it.
I love that, because you're right. Everyone wants a choice. Nobody wants to be told what to do. It is a very unsettling feeling. And it is for me too, when somebody's told you have to do this. Those are excellent rates. Is there anything in particular that you found that was, I don't know, just made it so successful? I think we got another comment here too. We used to make, Jennifer said, we used to make those who declined the flu vaccine wear a mask for the whole flu season, which they hated, and then sometimes would decide to get it. But that, hold on, I'm losing my my page here. And they hated that and would sometimes decide to get it, but then not really a thing anymore with COVID and masks. Yes, I get it. We're right. It's not such a thing because you're all wearing a mask now. So our staff just have vaccine fatigue, and very few have gotten either. Yeah, I have to say that is one thing that I feel has come out of this, is getting vaccination completed in other areas. Pneumococcal, influenza, hepatitis, whatever, I think is going to be a little more difficult than it has in the past. Our corporate organization, Jody is sharing, requires them, and so therefore our staff fall under the requirement. Medical and religious exemptions are accepted.
Yeah, this is a tough one. And I think even just reading through the responses that are coming in, I mean, it's split, right, between folks who aren't requiring it and those who are. And, Kim, to your point, with what we saw during COVID and the lack of feeling like you have a say or have a choice in that, I think that sort of leads us to this difficult decision. My gut feeling would be that whatever your facility or your corporation's policy was pre-COVID probably will continue to be the same post-COVID. It seems unlikely, given what we saw, that folks would move to mandating a flu vaccine. Again, with the fatigue that we're seeing in vaccines in general and like the uproar around the COVID vaccine mandates, it's hard for me to imagine that anybody would be moving in that direction, but perhaps I'm wrong there.
Oh, Christine indicated that she feels the education given to the families and the staff has helped our vaccination rate. Sure. I mean, it makes sense. Offer it, educate, be transparent, sincere, just like you do with, motivational interviewing, what's holding them up. Yeah, I mean, it does make sense. I think maybe, just my own personal opinion, that I think the influenza vaccine is easier to get people to accept it, to want it. And I think it's just because it's been around for a while. There's not as so much unknowns with the flu vaccine as with the COVID vaccine, where yep, this again. Yeah, I don't really want to, but I will, opposed to COVID vaccine. You know what? You give me that, I might grow another arm because we haven't got that research out yet. So that could be it, a little bit of it.
Kim and Kelsey, if it's okay, that response from Christine, I think that's such great feedback. We're getting such great feedback today. So thanks to everybody for that. And I was wondering for the group too, we're talking about so many vaccines right now, COVID-19 and now flu. Christine, I like what you said about the education piece of things. And I'm curious, what are people doing to get the education out there, but making sure it's not overwhelming? So Christine, I don't know, do you have any ways that have really worked to get that education out there where people are really receiving it, or anyone else? How do you get that information out there without overwhelming people? I'm pausing a little bit because I know sometimes it takes a minute to type it in chat, but I think just from past calls here too, I feel like I've heard e-newsletters, emails are being sent out. I think facilities include information on their websites, those personal conversations they're having, letters, anybody using anything like that or anything different. I feel like you probably have good ideas that maybe someone else hasn't thought of. So that feedback's really helpful. All right, we just got a comment. Thanks, Angie. It's interesting that very few of our residents push back against any vaccine. They just feel it's something that they should do. Staff is another story. I wonder if this is a generational thing. If their MD or nurse says it's a good idea, they trust this. We have done a fair amount of education about both vaccines, but those that have made up their minds I just lost my spot. Those have made up their minds that the vaccines are not safe, just will not be persuaded. Yeah, thanks for that comment, Angie. I think getting the information out there and having that education that's available, readily available for people who want it, for people who are ready for it, having that there for them, that's a great strategy. Christine had mentioned in chat, let's see, we have posters and handwritten education. I have done one-on-one education. It was in our newsletter, and I am the infection control preventionist and have written a letter for the families and gave information. Wow, that's awesome, Christine. lot of different avenues there. That's really helpful. Thank you. All right, if anybody else has any other ideas, definitely feel free to drop them in chat. I think the more ideas and the more creativity, the better. Another question I'm wondering, I know we have a good representation of nursing home leadership on the call today. So I'm wondering too, it seems like coordinating vaccines to be given on site at the facility has really helped for people who are eligible, who are ready to get those. Just having it on site and be really accessible has been helpful. So I'm wondering, are you able to arrange to give both COVID-19 and flu vaccinations on site? With that pharmacy partnership that you have, maybe it's a health department partnership, but are you able to give both of those vaccines or have both of those on site for people who want and are ready for both? Angie says we are. Okay, great.
Julie, are you also indicating that giving them at the same time? I mean, is that happening? Some of the calls I've made to some nursing homes I've had to talk to, that's something they're not doing. They're having separate flu clinics and COVID bivalent clinics. So I'm wondering if anybody's doing it at the same time.
Yeah, good question, Kim. Yeah, I was thinking kind of if you're able to get both vaccines, but yeah, is anyone kind of setting up one clinic at the same time where people can get both?
I'm not seeing it in the nursing homes, but I do see it in the community events. They're giving both, just so that people are poked in one space at one time, because it's hard to get them back.
Yeah, thanks, Makisha. Yep, if someone's ready to have both of those at the same time, yep, I think that's a great strategy. Another comment from Angie, we did co-administration opportunities for our residents and staff. Awesome, thank you for that. And then Jody dropped in the chat as well. The recommendations are to give at the same time, but we do not. Our medical director likes us to wait, lost my spot again, at least 1 week. This way, if they have a reaction, we can isolate which vaccine caused it. Okay. It sounds like you're able to get both of those vaccines though. So that's really great to hear that supply and access is not a challenge. All right, comment from Christine in chat. We are having difficulty getting the COVID bivalent. Our pharmacy stated that we have to give them a 2-week notice to receive the vaccine. We had a flu clinic at the beginning of October for all of our elders. Okay, thanks, Christine. Yep, sounds like you're able to get the flu shot, but sounds like maybe that same pharmacy you're working with takes a little bit of time for them. They need a little bit of lead time to get those bivalent vaccinations. Okay.
Christine, you're having difficulty getting the COVID bivalent. Our pharmacy stated they have to get them 2 weeks. Okay, but you will be able to get it within like the 2. I'm just trying to get at is if you're having difficulty with getting the bivalent, will you please reach out to any of us on the team, because we do have some access to some mobile vaccine clinics that we maybe be able to help that situation out.
I was just looking to see if we got a response on that, but yeah, absolutely. We have partnerships with mobile vaccine clinic providers in each of our states. So if that is something that you're struggling with, definitely reach out to Superior Health and we'd be happy to help connect you with someone who can come on site and offer those.
Absolutely. Well, thank you all so much for the great discussion today. And Julie, great questions. And Tony, Kim, thank you both for your wonderful presentations as well. I think the engagement in chat is really, really promising. So thank you all for engaging in that way and continuing to show up week after week. I'm going to go ahead and close out our call today since it is almost 2 o'clock Eastern. We will see you all next week. If you have any other questions, please feel free to reach out to any of us in the meantime. Otherwise, again, we'll see you all next week. Take care, everyone.